Today, we are diving deep into the critical guidelines for managing ureteral trauma. We're going to follow the patient's entire journey, from that very first moment of suspicion all the way through to the definitive surgical repair, breaking down every single high-stakes decision along the way.
Okay, so here's our roadmap. First, we're going to talk about how you even find the injury in the first place. Then, we'll step right into the operating room to see what critical choices have to be made under pressure. After that, we'll tackle the tricky scenario of a delayed diagnosis, get into the surgical weeds of different repair techniques based on where the injury is, and finally, we'll cover those injuries that can happen during other endoscopic procedures. First up, finding the injury. So, how do you even know you're looking at a damaged ureter? Well, the game plan completely changes based on one huge factor. Is your patient stable, or are they unstable and being rushed to the OR? So let's start with the more controlled situation, the stable patient. They aren't being raced into an emergency surgery. So how do we actually confirm the injury? Guideline 9A gives us our first crucial piece of the puzzle. It's all about picking the right imaging test. And there it is. The standard of care is a CT urogram. Now, what does that mean? It means a CT scan with delayed images. That delay is absolutely everything, because it gives the contrast dye time to work its way through the urinary system, which lets us see any potential leaks. But it's not just about ordering the test, right? You've got to know when to suspect an injury and exactly what signs you're hunting for on that scan.
This slide breaks it down perfectly. Your suspicion has got to be high in any major trauma, especially with penetrating wounds from something like a high-velocity gunshot. And here's a massive point. You cannot trust the urine. An absence of blood, or hematuria, does not rule out a ureteral injury. Now, on the CT, you need to wait for those 10-minute delayed images. You're looking for those classic signs: contrast leaking out of place, a kidney that's slow to light up, swelling, or a part of the ureter that just seems to disappear.
Okay, let's flip the script. What happens in the opposite scenario? The patient is unstable, way too sick for a CT, and they're going straight to the OR. How in the world do you find the injury then? This is where Guideline 9B comes in, and it's all about handling this high-stakes, time-critical situation.
The guidance here is a clinical principle, which basically means it's non-negotiable. If you didn't get imaging beforehand, you have to physically get your eyes on those ureters. You just can't assume they're okay. And to help with this, the guidelines give surgeons several techniques they can use right there on the table to be absolutely sure. Think of this as the surgeon's toolkit for when they're flying blind. You can carefully mobilize the ureter to get a full 360-degree view. You can inject dyes like methylene blue to see if any of it leaks out, pinpointing the injury site. If you're still not sure, a retrograde pyelogram, imaging from the bladder up, can give you a definitive answer. But look at that big warning at the bottom. A quick, single-shot IVP is considered unreliable. It should never be the only thing you use to say the ureter is fine. So, you've found the injury. The clock is ticking in the OR. The next huge question is, do you fix it now or do you wait? Well, the answer comes down entirely to the patient's overall stability.
And this slide just lays out that fork in the road perfectly. As you can see, Guideline 10A is crystal clear. If the patient is stable, you perform the definitive repair right then and there. But on the other side, for the unstable patient, Guideline 10B says you're in damage control mode. The priority is saving their life, stopping the bleeding, controlling contamination. The ureter for now has to wait. That means putting in some temporary drainage, getting the patient stable, and then coming back for a delayed repair later on.
But hey, it's not always a clean slice, right? What about a contusion, basically a really nasty bruise to the ureter? This is pretty common with the blast effect from a gunshot wound. Guideline 10C tells us exactly how to handle this more subtle but still very dangerous injury.
You know, the real danger with a contusion isn't the immediate problem, it's what could happen down the line. That bruised tissue can die off and lead to a delayed leak or a stricture that blocks things up. So this expert opinion says the decision hinges on how the tissue looks. If it seems viable, a stent can act like an internal scaffold while it heals. But if that tissue looks compromised, the safer bet is often to just cut out that damaged section and do a primary repair. Okay, let's shift gears and tackle a different kind of challenge. What happens when the injury is completely missed in all the initial chaos, and a patient comes back days or even weeks later with a fever, flank pain, or a fluid leak that just won't stop? The management here is a very logical step-by-step ladder. As Guideline 11A says, your first move, your first line of attack is to try the least invasive thing. You go in from the bladder, image the ureter, and try to place a stent across the injury. If that's a no-go, Guideline 11B says you move to Step 2. Place a percutaneous nephrostomy tube, which is a drain that goes directly into the kidney to divert the urine from above. And if the leak still doesn't stop, then you escalate to either placing a drain next to the ureter or going in for a definitive open repair. Now, Guideline 11C zeroes in on a very specific type of delayed injury, a ureterovaginal fistula, which can be a complication of pelvic surgery. The principle is the same: start with a stent if you can. But the success rates here are really key to understanding the full picture. And check this out. The data shows that this initial, less invasive approach can be incredibly effective. We're talking success rates for fixing the fistula with just a stent that range from 64 all the way up to 100%. That is a powerful first-line treatment. But what about the cases where it doesn't work?
Well, this is the punchline. If that initial stenting fails, moving to a definitive surgical repair, like a ureteral reimplantation, has a success rate that approaches 100%. It just goes to show how reliable this tiered approach really is.
Okay, time to get our hands dirty and talk about the nuts and bolts of the repair itself. Not all ureteral injuries are created equal, and the surgical strategy is dictated by a simple anatomical landmark: the iliac vessels.
This table lays out the fundamental difference in strategy perfectly. For injuries in the upper ureter, or proximal to the iliac vessels, Guideline 12A recommends a direct end-to-end repair. That's a ureter ureterostomy. For injuries in the lower ureter, distal to the iliacs, Guideline 12B says you're better off reimplanting the ureter into a new spot on the bladder. But notice the one thing they both have in common: the repair absolutely, positively must be tension-free. That is the key to success.
And getting that tension-free repair, especially when a whole segment of the ureter is missing, sometimes requires some incredible surgical creativity. A psoas hitch involves literally pulling the bladder up and stitching it to the psoas muscle to close a gap. A Boari flap is even more complex. You fashion a tube out of the bladder wall itself to bridge an even longer distance. These are elegant solutions that are essential for a good outcome. Finally, let's tackle our last category: iatrogenic injuries. This is damage that happens as a complication of another procedure, most commonly during your ureteroscopy for something like a kidney stone. The good news is, the management pathway here is very clear and systematic. And what's fascinating here is that this step-by-step process, laid out in Guidelines 13A and 13B, should look really familiar. It's basically the same logic we used for managing a delayed stricture injury. Step 1, you try the least invasive thing first, placing a stent. Step 2, if that doesn't work, you divert the urine from above with a nephrostomy tube. And only as a last resort, Step 3, do you escalate to a major open or laparoscopic repair, using those same reconstructive principles we just talked about.
So what's the big takeaway from all this? There is no single one-size-fits-all answer for ureteral trauma. The crucial thing to remember is that a successful outcome hinges on a flexible, dynamic approach, one that constantly adapts to the patient's stability, the timing of the diagnosis, and the precise anatomical location of the injury. It's all about being prepared with a clear plan for every possible scenario you might face, from the trauma bay all the way to the operating room and beyond.